My name's Emma Cramp. I'm one of the antimicrobial pharmacists at Leicester, and I also work with Phil Howard as one of the AMR project leads at NHS Improvement, and we've put together this workshop for you. So it's meant to be quite engaging and interactive. We've got some great speakers lined up for you to share some excellent pieces of work. So just to go through the aims and objectives of the workshop, it's really to share best practice to achieve the serious infection CQUIN 18-19. So by the end of this session, you should be able to share strategies for meeting the CQUIN targets, discuss ways of implementing good prescribing practices, and use examples, strategies discussed during this workshop to take back to base. So the content of the workshop, I'm going to start out by talking about networks, and I'll come on to why I've included that into the workshop. I'll briefly discuss what we're doing at Leicester, so we're implementing some ward rounds, and then I'll look at what data sources we should be using to help monitor performance. We have Dr. Hussain talking about behaviour change, and that's linked to AMS. Rashmi as well from Heart of England will discuss allergies and also linking that to AMS as well. And then we're going to hear from 2 hospitals, so how they're meeting the CQUIN targets currently. And then we'll have discussion and summaries throughout as well. So why did I incorporate networks into a stewardship workshop? Well, basically, NHS Improvement are doing mapping exercises at the moment, looking at various different networks to do with infection. There's so many infection networks out there, and actually it's apparent that they're all working in silos, not probably talking to each other. So I felt it was quite important to discuss how effective networks can be, especially for our purposes, talking about stewardship and resistance. So for Christmas, I got a network book from Santa, which is a really good read, actually. It's Networks in Healthcare, Managing Complex Relationships by Becky Mulby. And I would recommend that book to anyone who works in this field and who is participating in various networks. So basically, the book outlines what networks are. There's no hierarchies within networks, and membership should really be voluntary. So it's not like a traditional committee where it's very dynamic and the membership evolves over time. They're meant to be very collaborative as well, with the same perceived goal. So everyone's clear what the goal is, and they use this creative platforms. They're very motivating, informal. There's a distributed leadership across all of the members as well. So although there might be a chair who chairs the meetings, there's not just one leader. A leadership should be distributed between all members. And there's very much a culture of teamwork. So that's really what a network is. And through the mapping exercise through NHS Improvement, there's lots of regional networks, local networks, national and SPT networks, through a whole host of different topics. So there's a lot of microbiology networks out there, IPC, AMS, AMR, care homes, have infection on their agenda, and same with medicines optimisation networks as well. And reporting can be formal or informal, and normally, particularly within Leicestershire where I work, AMS is always a standing item agenda on the networks. So there's really 3 key areas where your network can develop. So those are power and leadership, purpose and direction, knowledge and learning. And you can ask yourself these 3 questions about your network and take that back to base on how your network can actually improve. So how decisions get made? how is the direction set, and how do you maximise social learning opportunities? So effective networks, really, there's one shared goal, and there's a focused aim that everyone's working towards. And obviously these expectations need to be realistic. They often address high priority issues, and there's a clear benefit for all participating within the networks. So that's where learning comes into play. If the networks have effective learning strategies for their members, the networks are a lot more effective. There's also strong personal relationships that build up over time, and clear, helpful outputs that are generated. So if you want to know more about networks and how you can develop your own networks, there's a lot of information on the Q Health Organisation website at the bottom there. So I just briefly wanted to discuss what we're doing at Leicester. So we've implemented some AMS Ward Rounds, where it's a daily ward round that happens. It's led by one of the antimicrobial pharmacists, and we're lucky if a micro or ID reg attends as well. So over about 2 or 3 months since this has been piloted, we've seen 162 patients, where 33 patients have been prescribed 2 agents, one prescribed 3 agents, and there's 189 antibiotics prescribed. And as you can see, meropenem features heavily in our antibiotic guidelines. We use it first line for red flag sepsis, so the majority of patients are on meropenem, and coamoxiclav features heavily as well. So from those 162 patients, we contributed to 87% of those, and we gave 339 pieces of advice. So that was mainly changing of the agent in line with guidance, advising on cultures, stopping treatment, clarifying duration. So what's interesting is the meropenem patients, so that's 71 patients. 68 of those patients received input and advice. 45% were advised to change to another agent within the guideline. Once perhaps allergies have been ruled out, diagnosis has been clarified, and switching to different choices of antibiotic when there's no signs of sepsis. 17% were advised to stop, and then we have a few others there as well, where we've optimized dosing regimes, looked at the duration of treatment, and looked at drug interactions as well. So there's a whole host of patients there that we've intervened on. So it's pretty much the same for coamoxiclav as well. 18% were advised to change to a different agent. 8% were advised to stop, and then we've got some other categories there as well. In terms of medicines optimization, 12% were eligible for an IV to oral switch, and then 11% we gave advice to optimize treatment regimes, whether that was due to renal function, therapeutic drug monitoring, for example. And then we've got other categories there as well, so drug interactions, ADRs, and drug administration. So I get asked a lot about where data should come from in terms of how they should be monitoring performance in hospitals. And basically, I just put this slide really quickly together, but it just highlights there's a whole host of different platforms where you can pull antimicrobial stewardship data from. So the most important place to gather data would be Trust internal data. But we've also got the Public Health England, AMR local indicators on fingertips. We've got RX Info, defined data as well that we can use. Public Health England second generation surveillance system can be used to pull resistance data as well, which is really handy. And then we've got pre-script data and the EPAC2 data for primary care. So that was just really to highlight where you can pull data from. So I just want to hand over to Dr. Hussain. So Abid is one of the medical microbiologists from Heart of England. He's also the Associate Medical Director and Director of IPC at Heart of England. Thank you.
Thanks very much, Emma. So we're going to change gears slightly. And whilst we talk a lot about AMR, how to manage it, how to perform our ward rounds and make those decisions, I want to just move away from that slightly and talk about the thoughts and behaviours behind those, either initial decision-making or de-escalation or lack thereof. So when we talk about what you need to run an effective AMS system, in my point of view, you require these three key things. Having appropriate resources, be it medical, pharmacy, etc., etc. A good laboratory providing results in a timely and appropriate fashion, and education. And the key thing about education, it's not simply a single point intervention, it's a regular program of education. And often with education programs, there's a lot of excitement about educating junior doctors, and of course that's important. I would argue the consultants are much more of a group that require continuous CPD education than junior doctors. So what we tend to find, particularly with those doctors who work on the front line and those independent prescribers, is that their practices can become embedded over time. And when thinking about how we're going to change behaviours, we've got to really ask ourselves three fundamental questions. What capabilities do those individuals have to perform their current role? Are there some psychological, are there some learned processes that lead them to behave in a particular way? What is the motivation that drives them to behave in the way that they do? And can those motivations be altered or manipulated? And are there any opportunities we can offer them? So the slides that Emma showed in terms of feeding back that data, be it local, national, regional, that data is very powerful in terms of guiding careful prescribing. Now, the problem is that with all individuals, be them medics, nurses, pharmacists, there are different groups of individuals. So this rather fuzzy bit at the bottom talks about Facebook. I'm sure everyone uses Facebook. And this is a timeline of when Facebook was first came online back in the early 2000s. And you can see you've got different groups of people. You've got the people in Harvard where it was first introduced. You've got the students coming in. Then you've got the 5.5 million or so US users. Then you've got the parents coming online. And at the very end, wow, grandma's on Facebook. So there's a whole spectrum of people who need to be considered. And in the technical speak, we refer to these people as a range of individuals, from the innovators, who are really the people who are designing these processes, the early adopters, the early and late majority groups, and then the laggards, those who are really have to be dragged by the scruff of their neck to instigate change. And within those groups, and I'm talking purely about prescribing at a bedside clinical level, the active resistors can be doctors, sometimes senior, sometimes junior, but mostly senior. Now, hands up anyone who watches TED Talks on YouTube. Does anyone watch TED Talks? Good, fantastic. So on YouTube, there is a guy called Sanjay Saint. He is the chief of medicine at the Ann Arbor VA Hospital in Michigan, and he's a professor of internal medicine at Michigan. He gave a TED Talk, which is on YouTube, where he talks about how you instigate change within organizations. And he says within his talk that the most dangerous group of people when bringing any sort of change amongst the hospital community are what he calls organizational constipators. And these are people who will say and do the right things in meetings, but when they leave the meeting, they go back to their old behaviours. They're the ones we have to really keep an eye on. And in terms of adopters, as we've described for AMS, you have early adopters and late adopters. And sometimes even the late adopters can be brought into the fold when they are provided with some appropriate data. And in my experience, there's nothing more powerful than local data. And if you can drill that data down to consultant-specific data, that's even more powerful. Then you can really add fuel to the fire by saying to your orthopedic surgeon, well, you know, your mate 2 offices down doesn't have any problems with his rates. What's your problem? And that drives competition between surgeons, and they are fiercely competitive. So I'd very much recommend that as a strategy. In terms of challenging behavior, behavior challenging can occur at different levels, and it's everything from the individual prescribing level through to the organizational level, and that's very much to do with your trust antibiotic committee meetings or your local guidelines, all the way up to national behaviours. And certainly we should always be challenging and questioning national practices and seeing, A, is that relevant to the way we practice our craft locally? And B, do we need to then feed back those changes back to the national level? But on the right-hand side, you can see what happens when things go wrong. When you have weak leadership, both clinical leadership and organizational leadership, there's a lack of challenge. You marry that together with inadequate resources, you then have the doomsday scenario of an increasing rate of your hospital-acquired infections, a poorly performing CQUIN, and poorly performing AMS. So when thinking about how you're going to challenge behaviors, designing the right intervention is absolutely key. Start off by understanding the nature of the problem. Is it prescribing in your AMU, your ITU? Is it certain types of syndromes that are problematic? Is it certain groups of antibiotics that doctors like to prescribe? Meropenem being an example. Once you've identified the nature of the problem and what those behaviors are, then think about who are going to be the key individuals. And what I would suggest is don't start just with one group. So with doctors as an example, because I have most contact with them, you can pick them off both at the bottom with your junior prescribers and at the top with your consultants. Decide how you're going to work on that intervention, where you're going to do it. And in my mind, the ward rounds Emma describes are absolutely crucial. You can instigate more change at the bedside, educating your doctors on the ward than you can bringing them together for induction. So clearly the place is going to be crucial. And when, that's very easy. Any chance you get, go for it. Understanding those behaviors are crucial because challenging those old practices with new practices can only occur once you understand the theory behind those old practices. If someone says, well, I've done this for 20 years and I've been okay, you'll say, well, actually, let's look at your local data. Let's see your personal prescribing data, and let's see if that still rings true. And I think before designing any intervention plan, consider the full range of effective interventions, and that can be it can be carrot. So, for example, one of my colleagues was telling me that when he was in charge of their an AMS group in another organisation, he would go around with a bottle of champagne and reward good prescribers with champagne. Not sure you can do that these days, but still, that's more carrot. And then, of course, the stick is repeated bad behaviour or repeated poor prescribing or lack of compliance will lead to a free trip to go and see the chief executive to explain why you're still poorly performing. So you can have both carrot and stick. And then finally, once you've identified what you think are going to be those best techniques, make sure they're clearly documented and you've got a clear escalation process, both for good prescribing and for poor prescribing. So this sort of thing you've probably seen already. This is a standard sort of cycle of quality improvement. Again, I'm not going to go through this in detail, but you can see that this is as applicable to surgical site infections and UTIs as it is to AMS. But the key thing is that a QI program like this, together with targets, a patient safety QI together with targets, then leads to a proper quality improvement strategy. And those targets, yes, they're going to be national in terms of CQUIN, but even in terms of local, you can have your own local targets which you can hold people to account with. Okay, thank you very much.
Thank you, Abid. And I'd like to invite Rashmeet Bogle to the stage, please, to discuss antibiotic allergies and stewardship.
Good afternoon, everyone. Thank you for inviting me here today. I'm Rashmeeth Bogle. I'm one of the antimicrobial pharmacists at the Heart of England Trust. I'm going to talk to you about a penicillin allergy label and the barriers to antimicrobial stewardship. So to begin with, about 10% of the population and 20% of inpatients at any time carry a pen allergy label. Interestingly, about 90 to 99% of these patients can be successfully delabeled after successful skin tests or supervised challenge procedures. An inaccurate label, a pen allergy label, can lead to the use of second-line antibiotics, so the use of fluoroquinolones, clindamycin, vancomycin, or multiple antibiotics, including carbapenems. There is a lot of evidence to suggest through large American studies, and there have been some Australian studies to suggest an increase in antimicrobial resistance, an increase in cost due to prolonged duration, increase in hospital stay, a possibility in the delay to the first dose of an antibiotic in acute sepsis, an increase in side effects, limitation to the extent of IV to oral switch, higher rates of C. diff, MRSA, VRE, and possibly ESBLs, and it can also possibly have an impact on mortality. So risk stratification of a penicillin allergy label is based on an accurate clinical history, a prescription history, and very importantly, the patient's comorbidities. The NICE allergy guidelines have a very nice structured approach to taking an allergy history, which I've put on my slide there. So things like, the drug name, the strength, the formulation, the description of the reaction, an indication for the drug that's being taken, the date and time of the reaction, duration of drug exposure, route of administration. And it's also really important to scrutinize any previous antibiotic prescriptions, because a lot of the time when we're working, when we go back and see what patients have had a year back or 2 years back, they have had penicillins and have obviously tolerated them. In cases where you can delabel patients, it's really important to close that loop, so ensure that the message is communicated with the patient's carers or the patient's family, and also it's important to delabel the patient throughout primary care and secondary care, because again, a lot of the time, if we have delabeled patients in secondary care, they go back into the community, that label sticks, they come back into secondary care, and we're faced with the same issues over again. So I just wanted to talk about risk stratification. So low-risk patients are patients with a history of non-specific symptoms, so GI tract symptoms or hallucinations, for example, non-immunological reactions, or a benign rash. And it's really important that these patients don't have any significant comorbidities. By this I mean unstable angina, brittle asthma, unstable COPD, because this automatically classes a patient as high risk. So high-risk patients are those patients that present with a rash within an hour of the first dose, and the timing there is the key. Isolated hypertension, upper or lower airway involvement, or obviously anaphylaxis. These patients can go on to have a supervised administration of carbapenems or third or fourth generation cephalosporins, or even penicillin desensitization after liaising with an infection specialist and an allergist. So last year, Krishna et al. Published a paper basically that used an app that allowed you to risk stratify patients. And this app is basically aimed at junior doctors, pharmacists, and nurses to empower us to be able to risk stratify our patients. And you can see there on the slide that once a patient has been challenged, if we look at the low-risk group, for example, if they are clinically reactive to penicillins, that penicillin allergy label remains. However, if they are tolerant to penicillins, then these patients can be successfully delabeled, and we can offer them first-generation cephalosporins and penicillins. So allergy delabeling should be a core part of antimicrobial stewardship. Unfortunately, due to resource constraints, we can't always have an allergist to be involved in delabeling patients. So we need to be in a position to empower our pharmacists, junior doctors, nurses to be able to delabel low-risk patients so that we can help reduce the burden of using alternative antibiotics and possibly reduce rates further of C. diff, MRSA, VRE, and ESBLs. So just to summarize, it's really important to have an accurate drug history, history of the patient's comorbidities, the history of the actual reaction with the penicillin, and then the risk stratification really depends on an MDT review, a supervised challenge, and then the assessment. And the assessment really has two outcomes. Either the patient is pen allergic and that remains as it is, or we're able to delabel a patient. In either case, I think communication is key. And this will allow us to have a more focused antimicrobial stewardship strategy. Thank you very much.
I'm from West Hertfordshire Hospitals, NHS Trust, and just wanted to share our experience with the CQUIN data. So for the 2C, which is the antibiotic review at 24 to 72 hours, we're doing quite well. We're quite pleased with our results. We are hitting about 98 to 100%. So all of antibiotics seem to be reviewed quite well. For the total consumption, reduction of total consumption compared to the baseline of 2016, we've actually done reasonably well. So we reduced nearly 7% in Q1. By Q2, our year-to-date was almost 10%, and Q3, because of the winter pressures, we have actually used a bit more, but we're still under reduction from our baseline. Just to share what we actually did at the beginning of the CQUIN was actually look at it and see, we looked at all our guidelines. So the first thing we did is we reviewed durations on our guidelines. So we had things like for community-acquired pneumonia, it would be 7 to 10 days. We changed it to 7 days or 5 to 7 days. And we looked at all the national guidelines. We looked at guidance from other hospitals. And there's been a couple of interesting talks that I've attended. And there has been a lot of talk about, I think UCLH and Royal Free have actually reduced their antibiotic durations on ITU to 5 days. And if you can do that on an ITU setting, so the ward-based setting, we should be able to do a lot more. But we did review all our durations. One of the other big things that we've done is we've empowered nurses to question prolonged duration and also asked them to empowered them to challenge the physicians about their IV to oral switch. So a lot of the time when I'm teaching nurses, I said, if you've got a patient, he's on 10 items on a prescription, and 9 of them are oral except the antibiotic, which is IV, they need to go and question and get an understanding. If a doctor then explains to them it's a bacteremia or something, that's fine. But we have empowered them to challenge, and that has shown good results for us. Also, we're doing a lot of education sessions. Our twice-weekly AMS rounds, as Emma highlighted how her rounds have been, it's really good, but we use it more for an education point of view. In our trust at the moment, we have a big problem of metronidazole, co-prescribed with peptides and co-amoxiclav. And I think we get a cohort of doctors, we educate them, we reduce our metronidazole usage, next cohort comes. So that's been quite a big impact on our education. Obviously, we do grand rounds at least every quarter. We do 1 AMS grand round. We're involved in the foundation year training, core medical training. We have regular sorts in all that. So we're always bragging on about antibiotics and durations and reviewing. And we also report all our reports at the divisional clinical governance meetings. So all the CQUIN data gets reported on a quarterly basis. One of the other things that we looked at the beginning of the CQUIN was all our pre-packs usage within the trust. And some of the things we did were very simple things, like majority of our pre-pack use for trimethoprim in our A&E was for female patients for UTI. So I know we now recommend nitrofurantoin, but we changed the pack sizes to there are pack sizes available at 6. So we were issuing out 14 tablet pack. Now we've reduced them to 6. Reducing pack of doxycycline to packs of 8 instead of 14. And there was also, when we looked at all the pre-packs in our hospital, we had things that were penicillin 250, we had penicillin 500 milligrams, we had clarithromycin 250, so we kind of rationalized, and that had quite a large impact on it. And we also have a pharmacy team referring all complex, unnecessary, prolonged antibiotics team. There's an email alert that goes out to me and the microbiologist, and we pick those up and we do review them on our ward rounds as well. So with the PEP-TAS consumption, looking at the second part of it, Q1, we were quite fortunate. We reduced by 35%, and that was not a credit to us. That was a credit to the Chinese factory. So I think the shortage resulted in a lot of usage. But by Q2, Q3, we've reduced. We are not reducing. We're only up to 5%. But we've had the Public Health England republish the data for us as a baseline. So somehow our data doesn't seem right, so I've contacted them, and they're going to correct our figures, so this might look a bit better next time I'm around. Carbapenem, unfortunately, we're not doing very well at all. We keep on increasing, so by Q1, we'd increased our usage from baseline to by 25%. We worked really hard in Q2. We reviewed each and every meropenem prescriptions and everything. We got it a little bit down. Q3, we've jumped up again. So this time now, we've put a new strategy in. I'm not sure whether we'll achieve our reduction in carbapenem. But our new strategy is now we only issue 72 hours of carbapenem, meropenem to our patients. We don't issue any more than that. And in that 72 hours, every patient issued is reported onto the pharmacy system, and it's emailed to the microbiologist. And if there's any inappropriate usage, emails back to me, and we try and stop it. So we have seen quite a good reduction in January. We're waiting to see what we'll achieve by the end of Q4. Thank you.
Thank you, Tejal. We'll save questions until the end of the next presentation, please. So can I invite Jonathan Snape to the stage, please? So Jonathan is an advanced pharmacist practitioner in antimicrobials from the University Hospitals of North Midlands. And Jonathan's going to discuss the CQUIN with us. Thank you.
Thanks, Emma. So in case anybody wonders where the University Hospitals of North Midlands is, and I often do, it's actually in Stoke-on-Trent. So for those of you that like holidays in the Lake District, we're just before you hit the roadworks at Junction 17. So we're going to talk about what we've been doing at UH&M to approach the CQUIN, introduce you to some of our CQUIN results, consumption results, some of our team members, and some of the data that we use, and also review to keep us on track. Also a little link to the hot topic in pharmacy world at the minute in terms of hospital transformation and the Carter report. So we're a 1,400-bed acute teaching trust over 3 sites, Royal Stoke, Bradwell in Newcastle-under-Lyme, and the County Hospital, which is the old mid-staffs that our trust took over in 2015. We're a major trauma centre, and we have many tertiary services like many presenters today. We're also a major research centre, and we have very close links to Keele University. So the 2017-18 Sepsis AMR CQUIN, I won't bore you with the individual details, but for us it's important in 2D because our targets for total consumption were 1% reduction, PEP-TAS 2%, and carbapenem 2%. And along with the quarterly submission of results and the review data and the sepsis elements, that's worth £840,000 to our trust. So the background to our approach really is the Start, Smart and Focus, the kind of algorithm for antimicrobial stewardship with reference to Llewellyn's paper in Antimicrobial Journal of Chemotherapy, that starting smart without a focus might actually increase antibiotic overuse. So a lot of our focus has been not on necessarily the empirical first choice, but the timely review of antibiotics and the narrowing of the appropriate agents. We've got a bit of a whiz of a data analyst at Royal Stoke, and I haven't got the faintest idea how he does this, but it's something to do with pivot tables. And what we use is a summary, a screenshot for this for each of our clinical areas to give them individual data down to individual ward area on consumption for the 3 indicators, which, as you can see for us in the top left, are all, middle carbapenem, and the right-hand side PEP-TAS. So the top line of graphs ends at the end of quarter 2. You can see we were just underneath the red dotted line, which is why Emma's asked me to come along today. We were doing pretty well with all consumption. We get the seasonal peaks around December each year, but at September we managed to be just below the target. Carbapenems, we did particularly well through the end of 2016, the start of 2017, and then we had the shortage with PIP-TAZ, and also then the aztreonam shortage. So we did see a slight drift upwards with carbapenem, but as we stand at the moment, that's coming back down. We're not complacent with carbapenems, so we're looking to introduce a code protocol for the remaining months of the CQUIN and also into next year to further control the use of carbapenems at the Trust. PIP-TAZ, again, we were helped by the earthquake in China, but we did review a significant number of our guidelines to remove PIP-TAZ, and we've seen the usage decrease significantly. One thing that I would point out on the bottom left graph, which is the one with the blue, red and green lines, I think if Emma had asked me to come along to present on the Q3 consumption data, it might be a different story, because our admissions during quarter 3 over the winter in Stoke have been particularly low. Most of our elective beds were turned over to medicine, and they were mainly populated by patients with flu plus complicated respiratory and also urinary infections. So our consumption in Q3, combined with a lower incidence of admissions, really went up. So we've got a real battle to pull the CQUIN back around for the end of Q4. I'd like to introduce you to some members of our team. Those of you certainly from West Midlands will know Dr. Banavathi, who's our consultant microbiologist. That's not him on the right. That's Bugsy McBugface, which was the winning name given to our bug that we had to help to engage or rather scare the children on European Antimicrobial Awareness Day. So that's the sort of thing that pre-reg pharmacists love dressing up as, and luckily we've got 4 pre-regs at Stoke, so we didn't have to fill the rota with any of the AMS team. But there's myself, Krishna. I've got 2 site-specific antimicrobial pharmacists, Jackie and Shane, one at Stoke, one at County. And we made a conscious decision when I came into post about 15 months ago that what was potentially a Band 7 pharmacist position, we actually turned into a Band 7 nurse position. And Jan's fantastic because she speaks nurse, which means that she can go out to quality nurses, ward managers, and really improve the engagement with a really important group of staff. Tej has already mentioned about conversations with nurses around changing from IV to oral. Jan's got extensive experience in the NHS across a bunch of different disciplines. And it really is a pleasure to have Jan who can sort of release Jan onto the wards, and she'll go about and convince the nurses that challenging the doctors, particularly for IV to oral switching, also for duration, is a good thing. We also have a non-urgent query email address. So if junior pharmacists in particular have got queries that aren't immediate around TDM levels, but more generic sort of why have they prescribed this and when is this going to be reviewed, then those guys can email the AM stewardship team, and we'll review that the next day on our ward rounds. Emma's touched on some of the external data that we see, so that's our PHE fingertips line for Q2, and also the rolling rate of antibiotic prescribing, and we can see from that at a snapshot how we're comparing with our peers and also with the national targets. The model hospital, I said I'd mentioned Carter. So Carter has a indicator within the safe medicines category, and we can see from that we're doing quite well on that as well at that particular time that was reported. In terms of support for reviews, we've got a number of strategies in place. We're still piloting the day 3, 48 to 72-hour review sticker. It's gone through various iterations through the antimicrobial stewardship group. But over the next few weeks, we'll be rolling this out across the wards in the Trust. We've got about 40-odd wards in total. And this is empowering the junior pharmacists to fill in the majority of the boxes and leaving the clinical improvement tick box for the ward round for the clinicians to decide whether or not there's sufficient clinical improvement to warrant a change from IV to oral switch. And it fits in as well with the CQUIN because you get an appropriate clinician review, either the consultant or the ST3 and above on the ward round, ID or micro or myself when we're doing our ward rounds. So we'll look out for that pink bordered sticker in the notes, and hopefully we'll start to pick up some good data from that to show that that's been of benefit. That's just a snapshot of our kind of ward round, pharmacists like rotas. So Krishna and myself tend to do the majority of the daily ward rounds. We have critical care and AMU ward rounds. Some of my colleagues will do other ward rounds either with or without microbiology or ID consultants or regis. But what drives the majority of that timetable, apart from the critical care elements, certainly the medical elements, is the consumption data that I showed in an earlier slide. So we can look particularly, for example, at Ward 84. In December, they use an awful lot of meropenem, so we'll target them for the next rotation. And that's a good example of some of the data that we can pull down to ward level. So the acute medical unit, AMU, at the county site had a big increase in PIPTAS prescribing and suddenly went up to the top 10 table. So we were able to allocate some time, some resource for the microbiologist and the antimicrobial pharmacist there just to sort out their prescribing. And the majority of that was just down to inappropriate choice of antibiotics compared to our guidelines for CAPs and HAPs. Jan's put together some flyers and some information based on other trusts' work in terms of a regular prompt. So we have a kind of a seasonal approach to education messages for engagement on the intranet site at the trust and also on staff room doors. And somebody once said that the back of lavatory doors are very good as long as the poster's laminated, because everybody's got to look at it at least once a day. So I'll leave that to Jan to sort that out. But what we're basically trying to do is just keep reinforcing this message about reassessment of antibiotics at 48 hours and also the conditions in which an IV to oral switch is appropriate. That's another example. Interesting, we've had the same problem at Stoke with overuse of metronidazole with some of the broad spectrum beta-lactamase inhibitor antibiotics. And also any missed antibiotic doses are treated as adatics because it's important that not only are people on the ward seeing the microbiologist and the pharmacist as challenging inappropriate prescribing, but also inappropriate administration of antibiotics. So whilst it's not specifically linked to the CQUIN, it's the overall antimicrobial stewardship that we're keen to reinforce on every ward visit. In the ASG, we put together an Antibiotic Excellence Awards, and this is a bit of a kind of a ad hoc, slightly informal certificate presentation that takes place based on outstanding work, either from junior doctors or for nurses or for pharmacists, and it just lightens the mood slightly. And also on our email signatures within the AMS team, we carry the Antibiotic Guardian flag and also a shortcut to our antimicrobial app, which is the MicroGuide app, which is free on people's phones, and that's got all of our trust antimicrobial guidelines to hand, and it's also available on all the PCs in the trust. That's an example of a page from our microguide. That's our aspiration pneumonia guideline. Many trusts have got something very similar, but that's the first port of call if junior pharmacists in particular have got a query, and if anything appears on the prescription chart that's a bit more random than that, then they'll often get in touch with us for a challenge. Thanks for listening. I'm sure you've probably seen that picture before, but yeah, that's about the dangers of the antibiotic resistance. So.